Oh. All right. Well, I'll look for that.
I thought you might have erased it.
Yeah.
Isn't that what was
You
going on?
said you were having some issues with
They're like at the end of
At
class
the end
last
of the
time.
class.
Wait a minute. Wait a minute. Wait a minute. Hang on. What's this? This is March. What day was your class?
13th.
There's a 13. Yeah, here it is, right here.
But it's not ours.
Yeah, it is. Wait. Hang on. Wait a minute. Hang on, I can tell. Wait. What time does that say? Hang on. 6:07, there it is.
So that's the one that needs to be uploaded.
That's the one that needs to be uploaded. Okay, so I'll do that. Now how do you get out of this screen? Alright. Okay, I'm sorry about that. Then I apologize for telling you to stop emailing me. Well, it was like every 2 seconds.
There's about 3 different things though, so.
Yeah, maybe in your mind.
It was 3 different things.
Okay, here we go. Ready? What's the little dingleberry that hangs off the base of your brain? The pituitary gland. It's divided into 2 parts. Say yeah. You got the anterior and the posterior. Say yes. Okay. This guy's the H cell. Are you with me? Now watch. How do you increase osmolarity? What are the 2 ways you can increase osmolarity? Add more stuff and keep the water the same?
Yes.
Right? Or keep the solute the same and decrease water. Say yes. You remember this, right? Okay. So, and as you recall, there are little receptors in the hypothalamus called osmoreceptors. Are you with me? Okay. Now watch. I'm going to relate all this stuff tonight to this guy right here. Ready? If you are bleeding your own blood, what's going to happen to your blood volume? What's going to happen to venous return? Stretch. Just say go down. Force a contraction. Say yeah. So what's going to happen to the amount of blood pumped to the lungs? And then the amount of blood pumped by the right heart is the amount of blood pumped by the left heart. So there's going to be less blood on the left side, less stretch, less force of contraction, say yes, and less systolic blood pressure. And write this down, never forget it. Systolic blood pressure determines capillary fluid pressure. So what's going to happen to capillary fluid pressure if you are bleeding your own blood? It will go down. Who's with me? So with a drop in capillary fluid pressure, at some point, interstitial fluid pressure is going to become greater than capillary fluid pressure, and it's going to force fluid from the cells and the interstitial space into the blood in an attempt to maintain blood volume. Do you follow that? So what's going to happen to the osmolarity within the hypothalamus if you remove water? Let's look. It will go
The osmolarity
in the hypothalamus will go
up.
up. There we go. And anytime you increase the osmolarity within the hypothalamus, that's going to trigger thirst. Say yes. And it's going to begin the synthesis of a hormone called antidiuretic hormone. And we learned, and I'll never forget it, any hormone that is synthesized in the H cell, where is it released from? The posterior pituitary. So the posterior pituitary will release into the blood antidiuretic hormone, ADH. Say yes, DH. Ready? And ADH has its effect on the distal convoluted tubules and the collecting ducts of the nephron. I will never forget this. Never. I explained to you that what happens to the osmolarity within the kidney as you move from the cortex into the medulla, the osmolarity goes
Down. No, up.
up. Say yes. Are you with me? That's a bad. So it goes from 300 to 600 to 900 to 1200. Say yes. I also explained to you that in the absence of hormones, the collecting ducts are impermeable to water. So the function of ADH, anti-diuretic hormone, anti-diuretic. What does a diuretic make you do? Pee. What do you think anti-diuretic hormone would do? Make you not pee. So what anti-diuretic hormone does, it begins to insert water channels called aquaporins into the collecting ducts. And it will cause water that was normally going to get peed out into your turlet to get reabsorbed back into the blood. And if you start reabsorbing water back into the blood, what will happen to your urine output? It will go down. That's why as you lose more and more blood, what's going to happen to your systolic blood pressure? It's going to go down. So what's going to happen to capillary fluid pressure?
Down.
Right. Because you saw my face and you were going to say up.
No,
And then I saw you.
Thinking
Oh,
interstitial was gonna go.
you're thinking good with that pencil.
Yeah.
So watch. Interstitial fluid pressure will become greater as the blood pressure begins to drop, and more fluid is going to get pushed from the interstitial space and cells into the blood to try to maintain your blood volume, so the osmolarity will increase. Say yes. And that will dump more and more ADH into the blood. So what will happen is, as ADH increases in the blood, what it will do is it will insert these aquaporins, these water channels, deeper and deeper into the collecting ducts. So as these water channels are moved deeper and deeper into the collecting ducts, what happens to the osmolarity? It goes up. That means more and more water get reabsorbed to the point at maximum ADH secretion, you are producing no urine. Say yes. Now, this is actually a pretty good time to be talking about ADH. All right? Here's why. It's St. Patrick's Day weekend. People are going to go out there and get liquored up. Are you going to get liquored up, Bella? No. Vicky, what about you? No? Do you drink? Oh, good. I always worry about people who don't drink. Colleen, do you drink?
You asked me, I said no. I drink coffee.
You don't put a little Bailey's in every once in a while? All right, I'm watching you.
Go for it.
All right, so watch.
Your life.
When you drink alcohol, ETOH, inhibits ADH's ability to insert aquaporins into the collecting ducts. That's why if you've ever gone out and had a little tussle with the bottle, right? When you first pee, there's some yellow to it, but your subsequent pees are clear. That's because alcohol inhibits antidiuretic hormone, and you're not able to absorb that water.
Eating a lot. Oh, makes so much sense.
That's why if you really go out and have a tussle, you're peeing out so much of that water, right? You wake up in the morning, got that cotton mouth. Sometimes it's so bad you dream that you're drinking water in your dream and you can't get enough to drink. Did you ever have that dream? No, I just heard people have it. Tell me you followed that. So watch how stupid my buddy is. I told you this, we used to go to like brewer games, and like beer's like $9 for like 2 ounces. So he tried to make beersicles. He's not the sharpest knife in the drawer. And he doesn't know that alcohol freezes at a much lower temperature than water and hops and barley. So he had a water and hops and barley sickle and a little alcohol on the bottom. So he goes, oh, forget that idea. So he just brought in booze. He goes, because I'm only taking sips of the booze, I'm not going to have to pee as much. I'm like, you don't get it. It's the amount of alcohol. So if you drink a higher proof alcohol, you're still going to be inhibiting that. Do you follow that? So I actually brought the computer there and showed him, and I drew the aquaporins. Tell me you got that, guys. So, yes.
So it also doesn't matter like how much water you drink while you're drinking, right?
That helps a little bit.
Okay, so
Because if you can decrease the osmolarity of the blood, right, that's going to push some of that water back in, and the osmolarity won't be as high. So if you mix like alcohol and you drink water in between, that will prevent a hangover, at least a little bit. No, Vicky, say yeah. How many people followed that? So we talked about the renin-angiotensin-aldosterone mechanism and ADH. Both of these are designed to increase your blood pressure. Now, what's really important to know is the renin-angiotensin-aldosterone mechanism, and specifically aldosterone, deals with sodium. And you know that when you reabsorb sodium back into the blood, water will follow by osmosis, right? Now, ADH deals with simply pure water. You got me? So in clinical, you're going to have to understand two pathologies associated with ADH. Number one is, it's called diabetes insipidus. Diabetes insipidus is when you have no ADH. So if you have no ADH, what are you doing all the time? You're peeing all the time because you can't reabsorb water back into the blood. So how do you treat diabetes insipidus? They have no ADH. You give them ADH. That's very good. Right. And ADH goes by another name. It's called vasopressin. Have you ever heard of vasopressin? That's ADH. Okay? The other one is where you have too much ADH. Too much ADH. And that's called syndrome of inappropriate ADH. You simply have too much ADH. So these people are not peeing, and they are volume overloaded. They are reabsorbing water back into the blood. They're not absorbing solute, they're simply absorbing the water back into the blood. So if you look at osmolarity, solute over solvent, yes? If you are reabsorbing solvent, so the solvent's going up, but the solute is staying the same, what's going to happen to the osmolarity? It's going to go down. So when the osmolarity of the blood goes down, it can cause fluid shifts into the brain, and these people can get their brains swelled. So what do you do for people with syndrome of inappropriate ADH? You have them drink. 10-year-old sucking down a case of Miller Lite.
Something that stimulates the water channel?
No, what they'll do is they'll treat that with diuretics.
So did you say that the diabetes and what is that other thing over there under number 1?
Diabetes insipidus.
Insipidus. That is too little ADH?
That's no ADH or too little ADH, right? So, and where's ADH released from?
Posterior.
The posterior pituitary. Now, did I tell you this story? Can I tell you this story real quick? About 6 or 7 years ago, I had a student in my class, right? He goes, Tim, my brother, he puts in real big pools for rich people in Milwaukee, and I was working with him, and he's like peeing all the time, right? I go, is he diabetic? No, he went to the doctor, and his blood sugar's fine, but he's peeing all the time. I said, he's got a tumor of his pituitary gland, right? He's got diabetes insipidus. So, Christmas Eve at 9:30, I am wrapping my son's Star Wars Legos thing, which, by the way, is outrageously priced.
Yeah.
It's ridiculous. Anyways, I get this phone call, and I look, and I'm like, who the hell is this? So I answer it, and it's the student. And he goes, Tim, my dad wants to talk to you. I go, it's 9:30 on Christmas Eve. And he goes, well, am I bothering you? I go, yes. He goes, well, it's really important. My dad wants to talk to you. So he gets on the line. He goes, what do you think's wrong with my kid? I said, I think he's got a tumor of the pituitary gland. He needs to go see endocrinologist. They'll snake a little thing up there to pull off the tumor, and he should be straight, right? Is that expensive? I said, I gotta go. So I don't see the guy, right? I see the student. He had a white Ford truck, right? And he was in clinical, and I saw him on the Racine campus, and he said, Tim, you're right, he had a tumor of the pituitary. And I go, yeah, great. You know, I didn't get to wrap my kids' Legos because of you. It's on your head. But I mean, the thing that shocked me, Christmas Eve, 9:30, something like, who does that? Who does that? And is it expensive? That's I couldn't make that story up. Tell me you got that. That is ADH. Now listen up. Watch. And I know you were dying the other day. Right? At 8:15, this is what I was looking at.
Slow, miserable death.
I try to make it a little bit entertaining, and I can't imagine what it would be like if other teachers just read a PowerPoint for 3 hours, right? You know what I'd be doing if I was in that class? And this is bad enough, right? I get it. I would have a gun, and I would take the bullets out of the chamber, and I would mash them into my skull manually, right, just to make the pain worse. Okay, watch. If somebody's bleeding their own blood, what's going to happen to the pressure in the afferent arteria? It's going to go down. And that's going to stretch those little juxtaglomerular cells, and that's going to cause the release of renin into the blood. Say yes. That's going to activate the renin-angiotensin-aldosterone mechanism, right? Vasoconstriction, and aldosterone is going to stimulate the sodium-potassium pump to reabsorb the sodium back into the blood, and what's going to follow? So what's going to happen to your blood volume? Venous return, can't do it anymore. You got me? That's going to be activated, and because you're bleeding your own blood, what's going to happen to systolic blood pressure? What's going to happen ultimately to capillary fluid pressure? So interstitial fluid's going to get pushed in. What's going to happen to the osmolarity? Look at the hand. Right? And that's going to stimulate the release of ADH, and ADH is going to insert those water channels in the collecting ducts, and more water is going to get reabsorbed. So the combination of the renin-angiotensin-aldosterone mechanism, the combination of ADH, and the combination of the sympathetic nervous system, all three of those things are going to reduce urine output and divert blood flow away from the non-essential parts to the vital organs, trying to maintain blood flow to the vital. Do you follow that? You see that? Yeah, that's good. See? So that was like day one. Remember the question on quiz number 1? Why does your skin turn cold and pale? Right? The question follows you. Now we just add to it. Tell me you got that. Guys? Okay. That's real good. Here we go. I tried. About 3 years ago, I decided to completely bag this, because I had 2 students in different classes actually have grand mal seizures while I was explaining this. They just sat there and listened, and all of a sudden they're like, right? And since since I didn't bring any Valium today, I'm going to simplify it. Uh-oh, we got the something. Are we still recording? Oh, we're recording. I don't feel good. Who feels good? Joe, you feel good? You look a little tired. Are you? Brittany, are you tired? Are you? You want to take like a nap? No. Vicky, don't you take naps? You don't? How do you live like that? Neither do I. I don't. All right, here we go. Ready? What was I talking about? Oh, simplifying stuff. Simplifying stuff. Okay? There's a question on the quiz. How does the kidney help maintain the pH of the blood? You got me? I was going to explain all this, and then I realized, you know what? I'm wasting my breath. So the result is the same. Are you ready? Here we go. I got to get these glasses on. Wait. Remember, the kidney can correct any pH disturbance if you live long enough, right? And blood flow to the kidney is maintained, right? So here we go. Watch. I explained to you that hydrogen ions and potassium ions have to be secreted. You got me? Who's with me? Now, bicarbonate, which is a base, right? And we're all about that base. Bicarbonate is filtered by the glomerulus. And if bicarbonate's not reabsorbed, then the blood will become more acidic because you don't have enough base bicarbonate to buffer those hydrogen ions. Are you with me, guys? All right. So how the kidney controls pH is by controlling the levels of bicarbonate. And how it controls bicarbonate, if the pH of the blood becomes acidic, right, it tries to become acidic. So if there's a drop in pH, the kidneys will secrete hydrogen ions into the urine, and it will reabsorb bicarbonate back into the blood. That's how it maintains the pH of the blood. Do you follow that? Now, if you recall, what are some of the byproducts of metabolism? Hydrogen ions. Now watch. Because we normally make hydrogen ions through metabolism, the kidney has to secrete those hydrogen ions, and what are they going to reabsorb back into the blood? Bicarbonate, right? So because hydrogen ions are always a byproduct of metabolism, the kidney in normal physiology is always secreting hydrogen ions into the urine. So the pH of urine is always acidic. Do you understand that? If your pH is basic, there's something wrong with you. That's why if you do a little urine dipstick, that pH of that urine is always acidic. It's always like around 5, 5.5, 6. It's acidic compared to the blood. Tell me you got that. All right. That's how. Now, watch. If the pH of the blood becomes alkaline, the pH goes up. Remember, bicarbonate is readily filtered by the glomerulus. So if the pH is alkaline, all the kidney will do is not reabsorb the bicarbonate in exchange for hydrogen ions. So the bicarbonate gets peed into the toilet, and the hydrogen ions remain in the blood. Say yes. There's some chemistry involved in that. I decided to skip that. All right. Each one leave 12 cents at the end of class. How many people got that? Okay. Listen up, because this is true. Embedded in the cells that make up the proximal convoluted tubules, there is a sodium-potassium exchanger. You got me? Sodium-potassium exchanger. And it exchanges sodium that was going to get peed into the toilet for potassium in the blood. So potassium will go from the blood into the collecting tubules. Whoops. That's terrible. So potassium will go from the blood into the collecting tubules. And sodium will get reabsorbed back into the blood. That's called the sodium-potassium exchanger. And it's 1-to-1. Who's with me? All right. Now watch. If the pH of your blood begins to drop, you have an acidosis. What's more important, to maintain the pH of your blood or potassium levels? pH, right? So what will happen is this, is the sodium-potassium exchanger will no longer exchange sodium and potassium. It will exchange hydrogen ions for sodium. So sodium will get brought back into the blood, and the hydrogen ions will be excreted. So what will happen to the amount of potassium in the blood? It will go up. So that's why an acidosis causes hyperkalemia. Who's with me? So watch. In an acidosis, instead of sodium being exchanged for potassium, sodium is exchanged for hydrogen ions. And if you can't get rid of the potassium in the blood because you're getting rid of hydrogen ions, the potassium level in the blood goes up. Say yes. Okay. Your blood sugar is 1214. What don't you have? So, what does the liver think? You're starving, right? So, what does the liver do? It takes fat and it makes beta hydroxybutyric acid. Notice how I abbreviated that. It makes acetone and it makes acetic acid. What are those known as? The ketones. And they get dumped into the blood. Say yeah. What happens to the pH of your blood? It goes down. And now, because you have more free-floating hydrogen ions, those free-floating hydrogen ions will stimulate peripheral chemoreceptors, which will feed back on the medulla, and you will start breathing faster and deeper. Say yes, that Kussmaul breathing. But now, because your pH is low, what happens in the kidney? Well, the kidney says, look, my pH is low. Oh. And that's exactly what it says. Oh. So instead of that little exchanger exchanging hydrogen ion or sodium and potassium ions, it will begin to exchange sodium and hydrogen ions. So what happens to the pH of the blood? It goes up. And what happens to your potassium level? It goes up. Say yes. That's one reason you develop hyperkalemia in DKA. What's the other reason? I'm waiting. I'm waiting. I'm waiting.
What was the question again?
The question is why, give me 2 reasons why patients develop hyperkalemia in DKA. Bella's going back. She's looking at her notebook. Hey, there might be something in here. I'm not doing, you're going to tell me. You know what I had today? Turkey jerky.
I had that today.
Did you? That stuff's good. Yeah.
So, Glenn, you don't know this?
Oh wait, you weren't asking for the increased ventilation.
Stimulates what pump? Yeah, that's unbelievable. That's unbelievable.
Did she get it right?
Yeah, she's exactly right. You told me that with a blood sugar 1214, what don't you have? No insulin. So one of the functions of insulin is to stimulate the sodium-potassium pump. I'll never forget it, right? Sodium or potassium is going to leak out through a potassium leak channel, right? What pumps it back in? What pumps it back in? The pump, the sodium-potassium pump. So if you don't have insulin to stimulate the sodium-potassium pump, can you pump that potassium back into the cell? No. So those are the 2 reasons that you develop hyperkalemia and DKA. SKA.
So how long does that take? Because there's people that go on ketogenic diets where the idea is to break down fat.
Yeah, watch. They always have to have a little bit of carbohydrate. Plus, the amino acids will cause a rise in insulin. So they're not completely insulin deficient. So, but they still will be goofy. Like the first, like after the first 10 days after you've exhausted your glycogen stores, you'll start producing ketones, and it takes a while for the brain to actually increase or upregulate ketone receptors in the brain. So you're kind of goofy for a while until you get that. So don't do that. Maybe that was it. Maybe you guys are all on a ketogenic diet.
Why don't you just gain all the weight back as soon as you start eating carbs again?
Well, if you don't eat like crazy, yeah. You know what I mean? Best way to lose weight is to read the textbook. Right? You know how that works? And it does work. Because you read it and it makes you want to vomit. So you nauseated and you don't want to eat. Maybe or just come to this class. Tell me you got that. Guys? Did I answer all the kidney questions?
Number 6.
What's number 6?
Hormones listed below affect
Oh,
kidney.
yeah, that's very good. I did ADH, right? Okay.
Blood gas thing?
Yeah, don't worry about that. I got that all worked out, sister. I know that. Yeah. So we're going to fight. That'd be funny if, like, you could have, like, grudge matches with your teachers. Like, teachers you didn't like, you could fight them. You know what they should have? A dunk tank for teachers you don't like. But only the dunk tank isn't water, it's like hydrochloric acid. They fall in there and their skin's getting all burned. And they're screaming, "Ah! I'll give you a C!" This class is dying a slow, painful death. Did you notice that? God, wait, I hit the wrong class. I am too. Would you leave me alone, all of you? Trying hard. And Bella, she yells at me. Made me feel bad. I'm in therapy for that.
I'm sorry.
You're not really. Alright. Where the hell is it? Did you see it? There it is. This is my favorite movie. You ever do any rocking to this? Huh? If you make a video of yourself watching this and doing some rocking, I'll give you extra credit.
How much?
Okay, here we go. Okay, I'm going to give you a hint because I like you guys. If you get this right, I'm going to be proud of you. How do you know you have increased blood volume?
Like, how do you know when you're just sitting here?
Like, how does your cardiovascular system know that you have an increase in blood volume?
Because it's the return to the right side of the heart.
But yeah, how does it know that before your system?
Because your left heart stretches.
No, look what I'm looking at.
Your right heart stretches.
Right. Where does all the venous blood first go to? What part of the heart?
Right side.
What part? There's 2 parts. Yeah. You know. Okay. You better write this down. Better not pout. I'm telling you why. We should have like a sing-along, like the last day of class. We could sing like, I don't know, what do you want to sing? Probably nothing, huh? Okay, watch. If you increase your blood volume, that's going to lead to an increase in venous return to the right atrium. Within the right atrium, write this down, a lot of rights. Within the right atrium, there are specialized cells. And these specialized cells respond to stretch. And when you increase the amount of venous blood back to the right atrium, what are you going to do to the right atrium? You're going to stretch it. And these specialized cells will then release into the blood a hormone called ANP, atrial natriuretic peptide. What does natriuresis mean? Natural. Right, and you forgot already.
Sodium.
Right,
Something.
right. Sodium. So diuresis means to pee water. Natriuresis means to pee sodium. Say yeah. So watch. Why was atrial natriuretic peptide released?
Because there was an increase in blood shrinking in return to the right atrium.
And the right atrium was stretched, and these specialized cells respond to stretch and release AMP into the blood. Say yes. Okay, that's good. AMP has its effect on all students. They think that class sucks. Get it, AMP? Okay, that was a weak one. You can write that down. That's sad. Okay, watch. AMP has its effect on the distal convoluted tubules. And AMP inhibits the sodium-potassium pump in the distal convoluted tubules. What does the sodium-potassium pump? You guys are bringing the A game today. So watch. If you inhibit that pump, where does the sodium stay?
In
The yellow brick road. In the collecting tubules, right? And if it stays in there, then it's going to get peed into the toilet. What stays with sodium by osmosis? Water. So what happens to the amount of sodium and water that you pee into the toilet? It goes up. So if you pee more pee into the toity, what's going to happen to your blood volume? It will go down. What will happen to venous return? Go down. And will there be any stretch anymore? No. So that will negatively feed back on the right atrium and stop the release of AMP. Hey, wait, wait. Ooh. Tell me you got that. Watch, write this down. AMP inhibits ADH and aldosterone. Both ADH and aldosterone, as I just explained to you, increase blood pressure by increasing blood volume. What does AMP do? It decreases blood pressure by decreasing blood volume. And it works in the exact opposite way as aldosterone. Say yes. AMP is the only hormone in the body that lowers your blood pressure. How many people got that? Guys? Okay, watch. I'm relating, don't be hating. Be dedicating. And abbreviating. And ameliorating. Yup. What's the problem in someone with congestive heart failure? What part of the left side of the heart? Right. The left ventricle is overstretched and weakened. It's overstretched and weakened. Are you with me? Okay. Bella, I'm going to ask you a personal question. You can choose whether or not to answer it. Okay? Is your left ventricle overstretched? Okay, good. Good. Does anyone here have an overstretched left ventricle? Has anyone been diagnosed with congestive heart failure? Then you don't have an overstretched left ventricle. Okay? You should write that down. See? So you think things are going bad for you? They're really not. You ain't got an overstretched left ventricle. What more you want? Watch. When the left ventricle becomes overstretched in CHF, overstretched, it will release a hormone called BNP, brain natriuretic peptide. Brain natriuretic peptide is called brain natriuretic peptide because it was isolated in sheep's brains. But what they found is this same hormone is released by cells of the left ventricle when they are overstretched. And if you have an overstretched left ventricle, what do you have? You got congestive heart failure. So one of the ways to test a blood test to determine if somebody's shortness of breath is related to CHF or something else is to draw a BNP level. And if it is elevated, that's diagnostic criteria for congestive heart failure. Congestive heart failure causes the release of BNP, and BNP works just like ANP to rid the body of excess sodium by inhibiting the sodium-potassium pump in the distal convoluted tubules of the nephron. Yeah. Do you follow that? That sounded really intelligent.
So BNP and ANP perform the same?
Yes, they do. Yes, they do.
So everything down to the pump and
Yep. But watch. When do you get ANP released? When your right atrium's stretched. You can have a non-stretched right atrium, and if you deliver that blood and this heart is failing, then it's going to get overstretched even though the right atrium is not being stretched. Do you follow that? Because it's failing, right? If you can't pump out all that blood, it stretches. So that's why this is diagnostic for CHF.
So is BNP a hormone?
Yeah.
But it won't reduce blood volume?
Yes, it will. It will attempt to reduce the blood volume.
Because you told us before that ANP is the only hormone that will lower blood pressure.
In a normal physiology.
But not for
Not in congestive heart. Right.
failure. Okay.
Right. Tell me you got that, guys. So now, and this test is relatively new, probably within the last 20 years. So when I was a nurse, they didn't have BNP. So one of the things, if someone comes in and they have shortness of breath, one of the things they'll draw is a BNP level to see if their shortness of breath is related to heart failure. Say yeah. Rock on.
Do you want that in part of our answers or
Yeah, that would be nice. It would be. Yeah. Yeah, Bella's making sure. I'm going to turn my ray gun on you.
I don't have to email you.
Oh, yeah, then talk. Say yes. Guys? Okay. Did I answer all the questions? Yes or no?
Did you explain the labs used?
Yeah, I always put in a couple of softballers. We already know this. Blood urea nitrogen and creatinine. Again, you're going to explain how you get blood urea nitrogen and the three nitrogen containing compounds that are excreted in the urine, and creatinine. Say yes. How you get creatinine, and which is the gold standard.
Don't make us write that.
Nobody likes that. I had my general class convinced that if you build up creatinine in your blood, you'll become a cretin. No, nothing. How many people got that? The other question is, why isn't there, why shouldn't you see red blood cells, white blood cells, albumin, and glucose in your urine? Is that a question? Or what should not be in urine?
Why would a physician check for protein red blood cells?
Right. And why shouldn't you find protein, red blood cells, white blood cells? Too big. They're caught by the glomerulus, so they never get filtered out of the blood. Should there be no glucose in the urine?
They should be being absorbed for energy.
100% of the glucose gets reabsorbed in the collecting tubules. That is, of course, listen up because this is true. Right now, anybody here a diabetic? Nobody? So you could eat a pound of little Twizzlers, right? Pure sugar. Pound of it. And your blood sugar should never get above 180. The renal threshold for glucose reabsorption is 180 milligrams per deciliter. Connie, does your blood sugar ever get above 180? No. So if her blood sugar never gets above 180 and the nephron is able to reabsorb a glucose level of 180, should she ever have glucose in her urine? No, right? So diabetics whose blood sugars are 200, 300, 400, they're spilling glucose into the urine because the nephron simply cannot reabsorb it fast enough. So a quick and dirty way to determine if you're a diabetic is peeth in a cuppeth, dippeth it for glucose, and if it's positive, you're diabetic. Say yeah. Those are the tests used to assess renal function. You better talk about the 180 milligrams per deciliter renal threshold for glucose reabsorption. Isn't that nice to know? I was going to talk to you about diuretics and the different ones and how they work. There's a video on that. Listen up because this is true. If you watch that video and talk about it and do a good job on the different diuretics and where they work on the nephron and how they work, big extra credit points. Yeah, you're looking at, this is no joke, plus 150 points. Plus 150 points. So if you blew up on a question, boom, you get that 50 extra credit, bam, you're living large. And that 150 extra credit points carries over to microbiology. If any of those microbiology instructors, they give you a hard time, you just tell them, hey, Timmy said. I told him one time. I go, this test is worth 110% of your grade. 10% of your grade in microbiology is off this test. They're like, can you do that? How many people got that? Okay, here we go. I'm going to explain to you arterial blood gases. Are you ready? This is what allows people to look on WebAdvisor at horticulture. I'm telling you, they don't get this. And you guys are going to get this. You are. Everyone is going to get an arterial blood gas. I don't care if you're taking the multiple gas, you're getting an arterial blood gas. You got me? Here we go. So, arterial blood gases, the first thing that shows up on an arterial blood gas is pH. Oh. All right? Now, a couple of things that I need to explain to you. For arterial blood gases, if the pH is less than 7.35, that is considered an acidosis. Are you with me? And if it's greater than 7.45, it's considered an alkalosis. You got me? All right. Now, watch. We have talked about pH, and really, I'm going to vomit out right now. Right? We've talked about it. And we've always talked about hydrogen ions. You got me? So, when there is a pH disturbance, you always look for the acidosis. Do you understand that? The most common acid-base disturbance that you will encounter is an acidosis, whether it be respiratory or metabolic. You got me? Now watch. If the pH is 7.52, don't look for the acidosis. The pH is alkaline. Look for the alkaline. Do you follow that? Do you understand? But if the pH is, even if it's normal, you don't go on break. You still look at the things that affect the pH and determine whether it's an acidosis or an alkalosis. Say acidosis. Guys, who's following this so far? All right, so watch. And again, the equation you absolutely love to hate. Would anyone consider getting a tattoo of this for extra credit?
Yeah, sure. For an A, I might. Guaranteed A. We'll think about
You'd have to get a tramp stamp of this.
I get a name, that's okay.
You would actually do that?
Yeah.
Do you have tattoos now? Yeah. No, this would have to be your first tattoo. So there. Okay. Guys, watch. Watch. If you ain't breathing so good, what's going to happen to the amount of CO2 in your blood? It's going to go up. So which way is the equation going to go? So what is the only system that can compensate for a respiratory acidosis? The kidneys. And how do the kidneys respond?
by increasing.
Right, by reabsorption. Well, watch how this works. Let's look at the kidney. Oh, there it is, 150 extra credit points. So what did I tell you? I told you, and I'll never forget it, I told you that how the kidney maintains the pH of the blood is by secreting hydrogen ions and reabsorbing bicarbonate, right? So if you have more hydrogen ions than normal, the kidney will try to secrete more of those hydrogen ions and it will reabsorb even more bicarbonate. Say yes.
Yes.
For real? Okay. Here we go. The cells of your body are making acid. So they're dumping extra hydrogen ions into the blood. Who's with me? What's floating in your blood that could grab them? And the only thing that's floating in your blood in this picture. So it will combine that hydrogen ion, lock it up in carbonic acid. So which way is the equation going to go now? It's going to go to the left. So what's the only system that can compensate, at least initially, for a metabolic acidosis? And how does the respiratory system compensate? By blowing off more CO2 than normal. You're making acid at the cell, you have to get rid of more acid at the lung. Just think of DKA, right? If you're in DKA, you breathe faster and deeper trying to maintain that pH. Are you with me? So if the respiratory system is causing the pH imbalance, the only system that can help is the kidneys. If through metabolism you are you're producing that pH imbalance, the only system that can help initially is the respiratory system. Say yeah. Yes or no?
Yes.
Okay. These you will have to remember. You will have to remember. I'm not giving them to you, ever. The normal pH 7.35 to 7.45. So arterial blood gases also measure PO2, or the amount of oxygen dissolved in the plasma of the blood. right? And that's measured as a pressure, millimeters of mercury, right? Then you look at your O2 saturation, and that's normal is 96 to 98%. You got me? The only reason you look at PO2 and O2 sat is to determine whether or not this person needs oxygen. PO2 and O2 sat have no effect on the pH. Do you understand that? What's the only thing that will affect pH? Oh, yeah. CO2. And normal CO2 is 35 to 45 millimeters of mercury. And then you look at your bicarbonate level. And your bicarbonate level is an electrolyte, so it's measured as 22 to 26 milliequivalents per liter. Who's with me? Guys? All right. So when you look at blood gases, right? I'm just giving you, I'm making this up, right? You can have a pH imbalance. Who cares what it is right now? But if one system is causing it, the only other system that can compensate is the one that ain't causing it. Do you understand that? So if you have a pH imbalance, it could be uncompensated, it could be partially compensated, or it could be fully compensated. And what I'm going to do is I'm going to give you examples of all three. You got me? Now watch. What an uncompensated pH imbalance is that if one system is causing the pH imbalance, who's with me? The other system hasn't done anything. You got me? It hasn't kicked in. If one system is causing that pH imbalance and the other system is working in the right direction, but the pH is still abnormal, that's a partially compensated. Who's following? So if one system is causing the pH imbalance and the other system is working in the right direction and the pH is within normal limits, that's fully compensated. Say yeah. Let me give you examples. I know that's a lot. Here we go. I'm going to give you a blood gas and then I'm going to interpret it. You got me? And then I'm going to give you a blood gas and you're going to interpret it. Are you ready? Here we go. Just so you know, I'm taking a summer class to make my G's not look like sixes. Okay, so let's look at this. First of all, what's the pH? It's an acidosis. All right? Now we look at the PO2 and the O2 sat. Is that high, low, or normal? It's low. So give them O's, right? Give them some oxygen. Give them O's. Now you look at the PCO2. Is the PCO2 high, low, or normal? It's high. So let's look again at our lovely equation. If the PCO2 is high it is going to force the equation to the right, and it's going to form more free-floating hydrogen ions. Say yes. So what has caused this acidosis? What system has caused this acidosis? The respiratory system, because the respiratory system controls carbon dioxide. Say yes. So this is a respiratory acidosis. Have the kidneys caught on? Look again. Is the bicarbonate within normal limits? Yes. So the kidneys have not caught on yet. So this is an uncompensated respiratory acidosis. How many people see this? You see it? Yes? Okay. I'm going to give you one. So go through it. Go through it. Tell me what it is. You better get this right.
It's an uncompensated respiratory, uncompensated metabolic acidosis. Because the respiratory system is still within normal range. It hasn't caught on yet.
How many people followed that?
Yes.
Watch. Look at the pH. It's an acidosis. Right? Look at the PO2 and the O2 sat. Give them some O's. Look at the PCO2. Is the PCO2 high, low, or normal? It's normal. So you know the respiratory system isn't causing this acidosis. The respiratory system is doing what it's supposed to do. The bicarbonate is low. That's because the cells of the body through metabolism are producing more hydrogen ions than normal. What's floating in the blood that can grab them? So what will happen to the circulating level of free bicarbonate if the cells are making more hydrogen ions than normal? It will go down. Does your bicarbonate go down? Yes. What's the normal? 22 to 26. Their bicarbonate is 18. Say yes. So if the cells are making more hydrogen ions, which way is the equation going to go? It's going to go to the left. So what should the respiratory system do to help out to try to maintain that pH? It should increase the rate and depth of breathing. So what should happen to the PCO2 if the lungs are helping out? It should be what?
It should also go down.
It should be lower than normal. Is it?
Yes.
Wait, is it lower than normal?
Not in this example.
No, not in this example, right? So this is an uncompensated metabolic acidosis. Who followed this? This is high-level thinking. It is. For a couple of years, I used to get pissed off at someone. Like, how are you not figuring this out? This is high-level thinking. But you need to get to that high-level thinking. You need to start getting this stuff. Yeah? All right, here we go. Ready? This is a fully compensated respiratory acidosis. How many people figured that out? How many people got that?
Where did we find out respiratory?
Watch. What did I always tell you? Look for the acidosis, right? You can't look at the pH and say, hey, that's fine, I'm going to go on break, update my Facebook stat. My patient's got a normal pH, right? You look at the pH, it's normal. Look at the PO2. O2 sats, low, give them some O's. Now look at the PCO2. The PCO2 is high. If the PCO2 is high, CO2 is an acid. Say yes, did. So if the CO2 goes up, it's going to force the equation to the right, and you're going to form more free-floating hydrogen ions. So what's going to happen to the pH? Down, right? You're forming more free-floating hydrogen ions. So what do you do? What's the only system that can help out in a respiratory acidosis? And how do the kidneys help out? They secrete hydrogen ions and reabsorb more bicarbonate back into the blood. So if the kidneys are helping out, the bicarbonate would be higher than normal. Is it? Yes. And because the pH is normal, it's a fully compensated respiratory acidosis. Yes or no?
So in a fully compensated metabolic acidosis, they're both going to be low.
In a full, yes. But don't think like that. No, I don't want you to think like that. That's how they teach you in nursing school, to think like that. And that's why nurses don't know anything. You're learning. Yeah, learn. Well, I'm going over stuff, I should say. Ready? Ready? Here we go. You look at the pH first, then the PCO2, and then the bicarbonate. You got me? You need to get this. How many people looked at that arterial blood gas video? Did you? Did it make sense?
Maybe you watched them in order.
Well, that's why I put part 1 and part 2.
I know, I started with part 2 and I was really upset not knowing I did part 1.
Didn't it say part 2 on it?
No, they're just in order.
Oh.
So I missed the first one, but
What is this?
partially compensated metabolic acidosis.
This is a partially compensated metabolic acidosis. How many people got that? Watch. Look at the pH. What is it? This is an acidosis, right? PO2 and O2 sat. The O2 sat's low. Give them some O's, right? The PCO2, they're blowing off more CO2 than normal. You got me? So what did I always tell you? Look for the acid. You don't even have to look for it. There it is. It's an acidosis. So what's happening? The cells of the body are making more hydrogen ions than normal. So the free-floating bicarbonate is going to grab them and lock them up. So what's going to happen to the circulating level of free bicarbonate if that's the case? It's going to go down. That's going to force the equation, to the left. So if the hydrogen ions and bicarbonate go down, then the CO2 has to go down in order for that equation to be in equilibrium. Does the CO2 go down in this case? Does it go down? Where is that? Where is it? Where the hell is it? There. Does the CO2, is it lower than normal? Yes. But the pH is still acidic. So this is a partially compensated metabolic acidosis. Yes or no?
Wait, can you re-explain what partially compensated means?
The system that is not causing it, the system that is trying to help out, is moving in the right direction, but the pH is still abnormal. That's how you determine compensation. Say yes. Guys, yes or no? Here, let me give you one more and see what you got.
Fully compensated metabolic acidosis.
This is a fully compensated metabolic acidosis. Why is it an acidosis? Because I told you, look for the acidosis, right? So even though the pH is normal, you look at the PO2 and the O2 sat, give them some O's. The PCO2 is low and the bicarbonate is low. So if you look at that, the bicarbonate is low. That's because the cells of the body through metabolism are dumping more hydrogen ions in. The bicarbonate that's circulating, going to grab it, lock it up in carbonic acid, decreasing the circulating level of free bicarbonate. What's the only system that can compensate for a metabolic acidosis? The kidneys, or the respiratory system, right? One of those two. So it's going to force the equation to the left. So in order for the equation on the left side and right side to be balanced, you've got to get rid of more CO2. Is the CO2 lower than normal? Is it lower than normal? Is it? Where the hell is it? Yes, it's lower than normal, right? So the lungs are helping, they're moving in the right direction, and the pH is normal, so this is a fully compensated metabolic acidosis. You need to watch those videos.
Where did you get the acidosis from? How-
Your bicarbonate is low, right?
Oh, okay.
You got me?
Yeah, I see.
So you can't just look at the pH and say, hey, and I told you, always look for the acidosis, right? No one's going to come into your emergency room going, I've been breathing like this for 15 years. Figured I should get it checked out, right? They're going to be breathing rapidly because something in their body is causing acid and they're trying to compensate to maintain that pH. Do you follow that? Most of the time, people come in and they're not breathing good. They're not breathing good. If you're not breathing good, you're going to retain CO2. And I told you, through metabolism, we make hydrogen ions. So the most common acid-base disturbance is an acidosis, so look for the acidosis. Say acidosis. All right. Okay, listen up because this is true. Tuesday, when you come in, I'm going to have you work in small groups, and I'm going to give you 5 blood gases, 5 of them. I'm going to give you I'll give you, I don't know, half hour, 40 minutes to complete them. You're going to explain why you answered the way you did. You with me? If you get all 5 right, an extra 150.
Could I be on Erica's team?
Right, did that, Erica.
Just watch the videos.
I know, yeah, don't do that. Don't do that. Don't do that. That'll only help you. Right? As a matter of fact, I'm pulling those videos. So if you watch those videos,
We could use our notes. I mean, if we work in groups, can we use our notes?
yeah. Yeah. You can't use your computer to look up online either. Because there's little blood gas calculators you can plug in.
So if the bicarbonate's high, then it's an alkalosis?
It depends on what the pH is.
Or if it's the pH is normal?
No, you then look at the PCO2. If the PCO2 would have to be high if the bicarbonate is high.
So it's an acidosis?
It would be an acidosis. Say acidosis. All right, ambulate homodosis. You got me? Can you do me a favor? Well, you won't. If there's a video on blood type and RH factor and RH incompatibility, if you could just look at that. It's a review from General, but I want you to understand the different blood types, and then I'm going to start the immune system. You need to know about that, and I'm going to teach you about the process of inflammation.